Dr. Fargo.
Okay, well, I'll introduce myself first. I'm Joel Loiacono. I am the Regional Director for Eastern Washington and Northern Idaho for the Alzheimer's Association, and one of my additional duties is as the Pacific Northwest Region 1 research champion. So it's my pleasure to introduce Dr. Keith Fargo. He is Director of Scientific Programs and Outreach at the Alzheimer's Association. He leads research programs and initiatives to accelerate the Alzheimer's Association's vision of a world without Alzheimer's and other dementias. Keith is a member of the scientific engagement team. He works with all 75 association chapters, media, and donors to grow understanding for the association's role in accelerating Alzheimer's research and to share scientific updates. Dr. Fargo is responsible for overseeing the data reported in the Alzheimer's Association's annual Alzheimer's Disease Facts and Figures, which is the definitive compilation of national statistics and information conveying the impact of Alzheimer's and other dementias on individuals, families, government, and the nation's healthcare system. Dr. Fargo directs the association's efforts to build participation in Alzheimer's disease research studies as a critical component of advancement in the field. He manages the association's role in recruiting participants for longitudinal early onset Alzheimer's disease studies, otherwise known as LEADS, the late onset Alzheimer's disease. Dr. Fargo also ensures the quality, responsiveness, and promotion of the association's Trial Match program, which is a free clinical studies matching service that connects individuals with Alzheimer's disease, caregivers, and healthy volunteers to hundreds of current studies. As an association spokesperson, Dr. Fargo addresses emerging Alzheimer's disease and research and has been quoted in a variety of outlets, including ABC News Go, CNN News, Time, and Wired magazines. Dr. Fargo received his PhD from Indiana University and completed a postdoctoral fellowship at Loyola University Stritch School of Medicine. Before joining the association, Dr. Fargo held positions as a research scientist at Edward Hines Jr. VA Rehabilitation Research and Development Program and an assistant research professor at Loyola University Chicago Department of Molecular Pharmacology and Therapeutics. So without further ado, I'll turn it over to Dr. Fargo.
All right, thank you, Joel. So I am going to attempt to share my screen here, and bear with me just a moment. All right, and let's see. Sorry, guys. Sometimes the technology you have to get used to. I've got a floating screen blocking my button here, but I think I have figured it out. There we go. All right. Does this look okay to people?
Looks perfect.
All right. Wonderful. Thank you. So before jumping into the actual meat of the presentation, just want to say a few words about the Alzheimer's Association here. This is our vision, a world without Alzheimer's disease and all other dementia. And I want to make that point, specifically about all other dementia, because even though we have Alzheimer's in our name, our full legal name actually is more descriptive of what we do, which is the Alzheimer's Disease and Related Disorders Association. And so we are working in care and support and research in for any kind of dementia. So if you know someone with Lewy body dementia, vascular disease that's causing dementia, et cetera, we're here to provide support for you and them. Also, we support research in all of those areas as well. Just real quickly here, too, on our mission symbol, which you can see over to the right. Looks like it's cut off just slightly. But sometimes people ask us what that refers to, and it's a human head on the left-hand side, or representative of a human head, and then a beaker, or really a Florence flask, on the right-hand side, representative of the scientific work that we do, whereas the human head is representative of caring for people who have dementia today. There we go. All right. So in terms of the roles that we play in the scientific community, there are several that you can see here, but I'm going to really focus today mostly on what we do on the left-hand side. This is about partnerships. We don't have time just briefly to go over, all of our partnerships and our whole approach to research, but I want to just give you a feel, for some of them. These are some of the groups that we have partnered with over time. Many of these actually are partnerships in funding. And so, for example, we work with groups like the Alzheimer's Drug Discovery Foundation and the Brain Canada to have grant programs that are co-sponsored by both organizations. But it's not, and sometimes these grants can be quite outside what you might normally think of in terms of grants. And so people probably look, at an organization like the Alzheimer's Association, and it's very easy to think about, how we're funding research programs and research grants sort of in the traditional fashion. But we also have some fairly non-traditional partnerships as well. So just as one example here, we've worked with the Alzheimer's Society of the UK to fund and begin a program called the Global Brain Health Institute Atlantic Fellows Program for Equity in Brain Health. And as part of this, we bring fellows from around the world actually to study within the GBHI structure, either at Trinity College Dublin or University of California, San Francisco, and they are eligible to submit pilot grants for us during their fellowship year. And so this has been a terrific program for us. These are folks who go back all over the world and take their learnings with them. And this is not just science, actually. Some of these folks are artists and filmmakers, but what they all have in common is that they're trying to make a difference against dementia. We actually hired one of the fellows, actually my colleague, Claire Sexton, who now runs our international conference program. Actually, we hired her out of this fellows program after we funded it. We were just so impressed with her. Another kind of partnership that we do is partnership around conferences, speaking of conferences. And so we've partnered with Cure PSP and the Tau Consortium. This actually started originally as a co-funding opportunity, a grant mechanism called TPEP, the Tau Pipeline Enabling Program. But that has since morphed and become larger because there's a lot of activity now around Tau. Sounds like somebody may be having a bad experience, but we have a lot of activity now around Tau. And so one of the things that grew out of this was the Tau 2020 Global Conference. This was in February of this year, and actually was the last dementia research conference held face-to-face in the United States that we're aware of in 2020. Of course, we're now all in this virtual world like we are today. Another example of partnerships is something called our Research Roundtable. So we realized that in order to really drive the development of especially medications, but progress in the field to enable that medication development, we had to have partnerships with the pharmaceutical industry. I mean, the fact is we need better medications for Alzheimer's disease, and in the U.S., the way medications get developed are through the pharmaceutical industry, who will frequently take the football, and run it across the goal line once academia gets it down the field quite a ways. And so we're really supporting both, the academic aspect, but also then the pharmaceutical aspect. Now, with this kind of partnership, this is not about money, because the pharmaceutical companies don't need our money. Although we do have small grant programs for very small companies, usually 50 employees or fewer, to support some of the work that they're doing. But a Lilly or a Biogen, they're not receiving grant funding from us. What we do with the Research Roundtable is we bring all of these pharmaceutical companies and biotechs together twice a year to work on some kind of problem that is slowing the entire field down. But working together, they can help solve that problem without necessarily giving one or the other a competitive advantage, which is very important because, of course, they have a lot of skin in the game, and they want to be very protective of their intellectual property. And so one of the roles that a nonprofit association can play is actually to be an honest broker, to bring these groups together. And because we have trusting relationships with each individual company, they know that we're not going to put them at risk for their intellectual property. And so that's been a terrific partnership for us over time. For those of you who follow this field, you may be familiar with the concept of ARIA, amyloid-related imaging abnormalities, which was slowing down the development of some of the monoclonal antibodies against amyloid. And it was actually the Research Roundtable that ended up defining what ARIA is, how common it is after treatment with these monoclonal antibodies, some of the genetic risk factors for that, et cetera, which has really allowed that kind of work to now move forward, whereas it was quite slowed for a while when ARIA first cropped up. We also have some strategic funding initiatives that turn into partnerships for us as well, and I just want to take you through a couple of examples of these. So one of them is DIAN-TU, which stands for the Dominantly Inherited Alzheimer's Network Trials Unit. And just to give you an idea of how this kind of thing can work, in 2008, DIAN, which is essentially a registry of people who have dominantly inherited Alzheimer's disease or familial Alzheimer's disease, was funded by the NIA. But that was just to create the registry. And then as the researchers who were running this registry decided, this is a great group of people to do clinical trials in, they wanted to set up essentially a platform trial that they could modify and swap drugs in and out of, et cetera, with this fairly unique group of people with familial Alzheimer's disease. Now, that's difficult to get, again, the pharma partners to work together, and it's also difficult to get NIA to fund some of the basic infrastructure work that goes into creating a platform trial like that. So the Alzheimer's Association provided grant funding to DIAN-TU to set it up as a platform trial, and then in 2014, that was in 2011, and then in 2014, once that was set up, the NIH then was able to come in and give them an additional $30 million to actually run those trials once we helped set up the administrative unit and the partnership with the pharmaceutical industry that would allow that to move forward. So that was about a 3-year jump in terms of how quickly that was able to get started. So when we're looking at partnerships, we're largely looking at areas in the field where something that we feel is critical either will not happen without us or will not happen as rapidly without us. And so those are two sort of key components in terms of what we're looking for in a partnership. Is there something that we can make happen that wouldn't otherwise happen, or is there something that would not happen as quickly that we believe needs to happen more quickly? And that's where we tend to partner. I'm also going to talk just a little bit here about the Global Alzheimer's Association Interactive Network. This is a project that is essentially a federated set of data, or really a federated group of sets of data. And through this partnership, we actually have made available freely to anyone in the scientific community or even non-scientists access to almost 500,000 clinical records on 4 continents from people from various clinical trials, longitudinal studies, etc. And these include things like, we call them the clinical records, but there are actually also genetic records associated with that. Most of the individuals, or many of the individuals, have imaging data associated with their records as well, or data from various biomarkers, not just the imaging, but also cerebrospinal fluid. And it's just a really neat tool that anyone can access from anywhere and use this data and actually publish on this data as well, as long as they're giving proper attribution to the people who collected that data. And anyone who puts their data on GAIN actually has complete control over who they allow to have access to the raw data. So what GAIN does is it makes that data discoverable, and you can do some limited analysis on the data within GAIN as well, just to look for things like feasibility. And then if it does look like your project is feasible, you then request the raw data from the data owners through the GAIN portal, and they have they own the lock, essentially. The data owner owns the lock. GAIN is really there to help connect people and make that data discoverable and to do the feasibility analysis. But of course, everyone has different rules on their data sharing. And so by placing your data on GAIN, you still control who has access to the data, but it does become available to find to the entire community. If you want to see this in action, I highly encourage you to visit gain.org. Just make sure you put that second A in, gain.org, and you can take a look at this for yourself. I'm going to give you now an example of how a partnership can grow very rapidly over time. And the example I'm going to use here is a study that we launched called IDEAS. IDEAS stands for Imaging Dementia, Evidence for Amyloid Scanning. And this was really born kind of out of necessity. So once the amyloid PET ligands were approved by the FDA for clinical use, we got to work and created some appropriate use criteria, et cetera. But then, of course, there was a coverage decision by Medicare. And you know, Medicare can decide one of 3 things when there's a coverage decision. Either, yes, we're going to fund this, we're going to cover it as part of health care for our beneficiaries. No, we're not going to cover it. Or third, coverage with evidence development, also called CED. Now, what CED means is that Medicare will cover the procedure, but only in the context of a clinical trial that is designed to give them more information so that they can make a full coverage decision, either yes or no, later. And so Medicare made a coverage with evidence development decision for the amyloid PET imaging. So we got to work and we said, all right, well, we need to create a clinical trial that will give them more evidence. And so we did, and that's what the IDEAS study was. And as part of IDEAS, more than 18,000 people received these amyloid PET scans. And then they were followed over time to take a look at what happens with their diagnosis, with their management plan, and most importantly, what happens in terms of their clinical outcomes. And so the data from the first aim of this study was actually published, I believe, late last year or sometime last year. And then aim 2 will be published, I believe, in the coming month or so. But the real reason I want to tell you about this is not so much to describe the outcomes, but to show you what happens when you create this kind of partnership. And so the partnership with IDEAS, I'm actually going to go back a slide for a moment. The basic partnership here was between the Alzheimer's Association, the American College of Radiology, the Centers for Medicare and Medicaid Services, or CMS, and then the 3 companies that produce the FDA approved ligands for amyloid PET imaging. And so the Alzheimer's Association committed $1 million to this trial. The companies who produced the ligands, together kicked in 19 million, and then the Centers for Medicare and Medicaid Services, CMS, kicked in the additional 80 million to make this a $100 million trial, which isn't bad for a $1 million investment from a nonprofit. So we're very excited about that. But of course, when you do a research study with 18,000 people, scientists, being the curious people that they are, they start to think, okay, that's great, but what if we added, genetic analysis to this? What if we added online cognitive testing so we can follow people over time, longitudinal cognitive testing? What if we add a blood test to look for blood biomarkers, et cetera? And so we actually have a number of add-on studies or ancillary studies that were launched as part of IDEAS as well. And with all of these ancillary studies, we now have a much richer data set than we would have without these ancillary studies. Now, one of the things that we learned from the first IDEAS study is that there were lower rates of positivity for amyloid PET in underrepresented groups, which you can see here. And that was true both whether the person had mild cognitive impairment or whether they had dementia. In both cases, we saw that people who were non-Hispanic whites had higher levels of amyloid than did the other individuals who were part of the study. And so that gets us thinking, well, why is that? And the fact is we can't answer that question without having more people who are not non-Hispanic white be part of this study. And so we've actually launched a follow-up study now called New Ideas. And the whole concept now behind New Ideas is to increase the number of people from those underrepresented groups who are receiving the amyloid PET scans, so we can get closer to understanding the meaning of some of these biomarkers in the different racial and ethnic groups, because they may not mean the same thing in these different groups. And that's important for us to understand if we're going to have an impact on Alzheimer's for everyone who is at risk for Alzheimer's disease. So this was just approved actually April of this year, and we are looking forward to getting this started as soon as we can. The pandemic is certainly putting a wrench in the plans like it is for everyone's plans, but we're very excited about getting this off the ground as soon as we can. I'm going to just play a quick video because I'm going to end here with a couple of things that really anyone can get involved with. And one of those is our professional society, ISTART. It stands for the International Society to Advance Alzheimer's Research and Treatment. If the sound on this does not come through, someone please just chat me and I'll move on. All right, so I'm hearing that the sound is not working, so I'm going to stop this and move on. We'll send you a link. I think Joel has it, and he can send you that link. All right, so somehow I've gotten kicked out of my slideshow altogether. I'm just going to get this started back up. I know I only have a couple of minutes here, so I'll try to go quickly through these last few slides.
Dr. Fargo,
right.
You're welcome to take as much time as you'd like this morning.
Oh, thanks. I appreciate that. Okay.
No problem.
So just to give you then a quick overview, though, I still do want to be respectful of everyone's time. So this is just a quick snapshot of where ISTART is around the globe. And again, anyone can join this society, although it is largely a scientific society. There are also members who are focused on health policy, on dementia care practices, etc. We have currently about 4,000 members from 70 countries, which you can see here on this map. So it really is a global organization and a global networking opportunity for people to be involved in. The top 5 countries by membership are listed here on the right. Most of them are English speaking, which is probably not a surprise. But the top 5 countries are the US, Canada, United Kingdom, Australia, and the Netherlands. But we certainly have members from many, many other countries as well. So in terms of the iStart, one of the most important parts of iStart, I would say, are the professional interest areas, or PIAs, we call them. And you can think of these as sort of special interest groups. And when we put on conferences, which is usually several times per year, the PIAs tend to have special sessions within the conference. They publish frequently together, so a number of white papers and recommendations and diagnostic definitions, et cetera, have grown out of these professional interest areas. So it's a very active group. We also offer training through the professional interest areas, mentorship, awards, networking, all of these things that are so critical to making science happen faster. In terms of I have this slide up here mainly to show you the variety of different kinds of professional interest areas that are part of iStart. And mainly too, to show you that most of them are scientific, again, focused on things like neuroimaging, neuropsychiatric symptoms. But we also have a professional interest area focused on health policy. So if policy is your cup of tea or where you're working, we have a professional interest area for that. We also have a professional interest area looking at diversity and disparities in Alzheimer's disease. As well as one that is really mostly about the demographics of the members, and that is the Alliance of Women Alzheimer's Researchers, because they have really more challenges with professional development. And so this is a group that formed within iStart for the members to support one another in some of these professional issues. And so professional development is really their main focus. We have a number of publications. Alzheimer's and Dementia is our flagship journal. It's the #1 journal in dementia science. The impact factor right now, I believe, is 12 point something. But then we have a number of other publications too, and I'd like to point out specifically translational research and clinical interventions, and diagnosis, assessment, and disease monitoring, which are both open access journals in the same journal family with our flagship journal, Alzheimer's and Dementia. And of course, every year we publish something called Alzheimer's Disease Facts and Figures, and we can send you a link to that if you'd like. Or if you want to wait for that, it's alz.org/facts. And by the way, for iStart, the quickest URL for that is alz.org/iStart. Just remember to put in both A's, ISTAART. And then finally, I want to leave you with this, which is our International Research Conference that we hold every year in July. And of course, like most other conferences this year, it's going to be virtual. And because we've made it virtual, we want to really take advantage of the opportunity to make this as broadly available as possible. So in addition to being virtual, it is free. It's free. So everybody here, everybody sees this, I encourage you, if you're interested in dementia science, register. It costs literally zero. And if you have students or people who work for you, who maybe you attend AAIC all the time, but it's been too expensive for them to, this is really an opportunity for everyone to participate in our scientific conference this year. To give you a sense, our record registration number for iStart in prior years was just about 6,000 people. And this year, we've had registration for the conference open for just under 3 weeks, and we already have over 10,000 people registered. So we're expecting this to be a very large event. And again, being free, please consider attending. One last thing, I would encourage you to download the Science Hub app. We all have smartphones today, and the Alzheimer's Association has created an application for your smartphone that really attempts to curate what people see and hear from the popular media, right? I mean, we've all heard stories of, there's this new cure for Alzheimer's disease, right? But then you read into it a little bit more closely, and it's a study that has been done in mice, right? Which is not to downgrade the importance of that research. It's absolutely critical research is happening in animals and cells in a dish, et cetera. But that's a long way away from your doctor's office, right? And so when those kinds of things crop up in the media, we curate them through this app, and we also provide expert commentary on them. And again, free to the public. Anyone can download this. Just search for Science Hub in your app store, either Google or Apple. It works on either one. Just search for Science Hub, 2 words, look for our mission symbol there, and you can install that and have that curated scientific content. So I'm going to leave it at that. We do have our walk season coming up, so you're seeing here some beautiful images from that. But largely, I just wanted to say thank you for your time and your attention today. So I'm going to go ahead and stop there.
Thank you so much, Dr. Fargo. I have a number of handouts. Oh, go ahead, Joel.
I was just going to ask you before we start questions. We got, we have a lot of researchers in this group. Thinking back to your days working on the bench, on the research bench there, what resource that the association has, or partnerships that the association have, would you recommend to a researcher as the most valuable that they could use to help them out with the research that they're working on right now?
Yeah, great question. So I would say right now, because we are in various stages of stay-at-home orders, it's social distancing, et cetera. It's very difficult for a lot of people to be doing the kind of research that they normally do, and so we're very proud of the fact that we have data available from almost 500,000 people to anyone in the research community through GAIN. So GAIN, again, GAIN.org. Huge source of data. So if you can't get into your laboratory, you can still access data that has been collected by other people, and you may find the next breakthrough, by your analysis of that data in a way that no one's ever thought of before. Once we get back to normal, and even before then, I would say I would say in terms of the most valuable right now, I think it's GAIN, just because you have access to data that you may not be generating yourself right now. Number 2, and I would say number 1 in normal times, would be iStart, just because that networking and collaboration is really the lifeblood of science today, and that's a great way to join with other researchers and be able to network and create those kinds of collaborations is through that professional society. So I would say that's number 2 or number 1 in normal times.
Dr. Fargo, can you hear me?
Yes.
Okay, good. My name's Marcy, and I have a couple questions for you.
Yep.
Back to the amyloid PET scan study, you said that you saw there was a higher rate of the amyloid in non-Hispanic, Caucasian, or white groups.
Yep.
Do you think, and I know you said they need more folks of color to participate or who are Hispanic, but I was just wondering, it seems to go against I'm not sure I'm thinking about it right, but when I think of health disparities that you guys have researched, and how, for example, someone who's African American is twice as likely to have Alzheimer's or some form of dementia as a non-Hispanic white person, how does that am I thinking about it wrong, or is it just that there's too small a group? Because I thought you said that they saw more of the amyloid in the non-Hispanic white population. Did I hear that wrong?
Yeah. No, you heard it right. That's true. And so this is and it's also true that African Americans are about twice as likely as non-Hispanic whites to develop Alzheimer's or another dementia during their lifetimes. And Hispanics are about 1.5 times as likely as non-Hispanic whites. Now, we don't fully understand why that is. And I think we also have to and this is where it gets difficult. We have to make a distinction between biological Alzheimer's disease, which is amyloid plaques, tau tangles, and neurodegeneration, and clinical Alzheimer's disease. So clinical Alzheimer's disease frequently does not match up perfectly with biologically defined Alzheimer's disease, or we might think of it as biomarker confirmed Alzheimer's disease. One piece of evidence in that direction, which I think is particularly compelling, is that when you look at the older clinical trials, and in those cases, virtually everyone was selected for the clinical trial based on their clinical presentation. This looks like Alzheimer's disease. And then you follow those people to autopsy, about 25 to 30% of the time, their clinical syndrome was not caused by biological Alzheimer's disease. Instead, we learned it was vascular dementia, Lewy body dementia, or some other form of some other biological problem that was causing that clinical presentation that was called Alzheimer's disease, right? Even though it probably wasn't actually Alzheimer's disease, it was one of these other causes. And so that's where we have a lack of understanding, right? Why is it, what else may be happening? And it's very light in the individuals who were in this study who were not non-Hispanic whites. And I actually want to, if I could go back a few slides here, I actually think there's a very telling group in this. Can you guys still see this slide?
Yeah.
I would draw your attention to the Asian Americans, because one of the things that we've learned in recent years, especially through the
Sorry, we can't see it up on our screen. Sorry, I thought I could see some general slides, but not a specific slide. Sorry.
Oh, okay. I think I might be paused. Let's see here. Okay.
There
How about
we go.
now?
Okay.
Okay, great.
Yeah.
Yep. So if you look at the Asian American group, one of the things we learned in recent years through the work of people like Rachel Whitmer, Elizabeth Rose Maeda, et cetera, who are doing great, epidemiology work, is that Asian Americans actually have a lower incidence and prevalence, or at least it looks that way, than non-Hispanic whites, which is opposite of what you see in African Americans and Hispanic and Latinx populations. Yet they also have lower levels of amyloid, if they, at least according to this study. So that's an interesting point, right? What it tells us is probably one of two things is happening. Either the amyloid means slightly different things in different people because of other factors that also play a role in the development of the clinical syndrome. And we don't know what those other factors might be yet. There are some hints in the literature in terms of life stressors, in terms of where a person was born. For example, people born in the stroke belt, even if they move away, have a higher risk for dementia later on. And so it's probably just more complex in these other groups because we haven't studied them as much. And so what we've landed on are these things that are very predictive in non-Hispanic whites, but are not doing as well of a job in terms of predicting in other groups, which is unacceptable. It's unacceptable. I mean, we have to understand this better in everyone. And so the other thing I think that was playing a role here is that the way this study was run is that the amyloid PET scans were all done in these tertiary care clinics. And so the people who so this is not a representative sample from any of these racial and ethnic groups. These are people who made it through care up into tertiary care in a location that had a PET scanner and that had access to these radioligands, which are very short-lived. Most of the time have to be produced in a cyclotron within a few hours of their use. And so again, we cannot assume that this is representative at all, which is really what the new idea study is about making sure that we do have a much more representative sample so that we can better understand what this difference may mean.
Great, thank you so much. And I have one additional quick question. If you were looking, oftentimes I'm in the role of applying for a grant that maybe for the CDC or the National Alzheimer's Association, where they're looking at us putting in like pilot kind of interventions where it's not randomized. It's oftentimes more process outcomes because the time frame, you don't have enough time or money to look at some of the biological outcomes for people. And so you put up a slide with the different sources of research, and I often use, I forget what it's called, but it comes out once a year, and I use that research journal a lot when I apply for grants. Is there any of the others that you would say I could look at, that it would be a good thing to look through in terms of citing things when I'm applying for these kind of grants that aren't as high dollar value and they don't give you the money to do like gold standard?
Yeah, absolutely. I would take a look at ADI, Alzheimer's Disease International, who they put out reports fairly frequently that are very high quality. So a great source of information there. I think you were referring to Facts and Figures as the one that comes out every year.
Yes. Yep.
Absolutely.
I use that all the time when building a case or looking. So it's really helpful. But it's also like I used to work with immunization years ago, and the CDC had of course now I can't remember the exact name, but it's like the guide. It's a guide that it's like your best practice guide, and it shows all the interventions that have been tried and which ones are more gold standard. And so oftentimes if you're going to be doing work in that field, you refer to that, or you even use something that's worked, or you say it didn't work because it's in there. But I don't always find that there is a place for that with Alzheimer's and dementia. Even though the CDC has a great page, but it doesn't have sort of I wish I could think of what it's called, a community guide for best practice. That's what it's called for immunization. And I didn't know if something ever existed like that for Alzheimer's or dementia that you're aware of.
Yeah, well, I'm not familiar with the community guide, so I don't know whether there's something that's similar in Alzheimer's and dementia. But I think I would give you two pieces of advice as a grant applicant. Number one, there's been a lot of sort of worry in the field that studies that do not include some of the biological markers, such as the imaging, PET imaging, et cetera, may not be funded at the same rate that others that do, especially after we published a paper with the NIA in 2018 called the Research Framework. And that research framework really did put a lot of emphasis on biomarkers, but both the Alzheimer's Association and the NIA define that quite broadly. And so the biomarkers don't necessarily have to be things like amyloid PET imaging or even, blood or cerebrospinal fluid. It's really broadly defined. It can be things like, how frequently is a person using their computer, right? So really any kind of objective measure almost could be defined as a marker. And so, when you're creating a grant application, as long as you have something in there that is objectively measurable, that might be telling us something about what's happening clinically, largely that will check the box for biomarker. And then the other thing I would say is if you're applying to the NIA, but also the Alzheimer's Association, is contact us, right? So with the NIA, you're going to be contacting your program officer. for the Alzheimer's, and they love it. I know everybody, especially if you're a young researcher, people get really nervous about doing that, but believe me, those program officers want to hear from you. And we do as well. So on our grants page, there's an email address. I believe it's grantsapp@alz.org. And I think there's also a phone number there too that will put you in touch with our grant staff. And they're lovely people. And it's their job to help you, and give you advice on how to write that grant application in the way that you have the highest chance for success. Because we want to fund good ideas. And we would hate to have a good idea go unfunded because a person had a question about, the approach and did not reach out to us. So I encourage you, if you're applying to us, please, please, please do get in contact, and we can help you make sure that your grant application is as strong as it can be.
Great. Well, thank you so much for your presentation today. I'll let someone else ask a question now. Thank you.
Yep.
Are there any other questions for Dr. Fargo this morning? Okay, well, I'm not hearing any, and so on behalf of our Alzheimer's Research Network, which brings together researchers and other interested parties here in the state of Washington, we really appreciate your time this morning, Dr. Fargo. And for all those who are joining, I do have a number of resources as well as the websites that Dr. Fargo mentioned throughout the presentation, and I will send that out along with the recording as soon as it's ready. So thank you so much, and I hope everyone enjoys their weekend.
Thanks all. Bye.
Thanks, Steve.
Thank you. Bye.